Good afternoon. I'd like to welcome you all to our November Marin Coalition virtual presentation featuring our guest, Dr. Matt Willis, the Public Health Officer for Marin County. My name is Scott Pinsky. I'm the chair of the Marin Coalition. Due to the pandemic, we're continuing to present all of our events live, virtually, and free to the public via Zoom, and we're glad that you're here. We're going to begin just in a moment, but for those who logged in and attempted to join us last week, I want to again express our apologies that we were forced to cancel that event on last Tuesday. We're sorry for any confusion that may have caused, but we were fortunate to be able to reschedule Dr. Willis to today's presentation, and we're very happy that all of you are here with us. As always, we're going to be recording this event. So if you or anyone that you know would like to watch it later, that'll be available on our website, marincoalition.org, under our archive page. This will be our last program for 2020. We will start again in January with more Zoom presentations. For now, we invite you to send in your suggestions for future topics and speaker ideas. We will send out some program information as soon as we have our schedule finalized. And lastly, for those who do not know us, Marin Coalition is an all-volunteer, nonprofit public affairs forum based here in Marin County. We welcome everyone to consider supporting us either by becoming a member or making a donation, which you can do on our website. Last thing, we have a new technological advancement for you here today. We are enabling what we refer to as closed captioning, also known, I guess, as subtitles. So if there is any sound interference that prevents you from hearing what's being spoken, we can invite you to enable the subtitling function in which you will actually see at the bottom of your screen the text of what is being spoken. It's probably limited by the technological advancement of that particular program, but hopefully it works fairly well. I've never used it before today. So the way that you do that is you go to the bottom of your Zoom screen, you'll see closed captioning down there. And then there's a little arrow to the right. You click on that and you hit either show subtitle or close full transcript. And that should give you the actual written verbiage of what's being spoken. Okay, let's move on. Today, we're honored to welcome back to our podium Dr. Matt Willis. A Marin native, Dr. Willis has been the county's public health officer since 2013. He calls on experience as a physician, an epidemiologist, and a community member to guide public health strategy for Marin. A champion of innovative and highly collaborative approaches, he co-founded RX Safe Marin Coalition to address the opioid epidemic. Dr. Willis has served in the U.S. Public Health Service as Director of Primary Care on the Navajo Reservation, and also at the Centers for Disease Control in Atlanta, where he conducted research on outbreak investigations in the United States and abroad. He holds a medical degree from Temple University, and he completed a master's degree in public health and his internal medicine residency at Harvard. He's published his research on numerous topics, including work on tuberculosis, opioid usage, and disaster response. Just to prove that all work and no play is not the Marin way, Dr. Willis is an avid cyclist and has served on the U.S. national cycling team as a professional road cyclist from 1987 to 1990. The COVID-19 epidemic is more than a professional concern for Dr. Willis. It is personal. In March, he announced that he had been diagnosed with COVID-19, Marin's 39th diagnosed case. He was forced to self-quarantine from his family, but happily he made a relatively quick recovery, although I'm sure it didn't seem quick to him. And he was able to resume his duties, leading the county's response to this crisis. It is my privilege and honor to present Dr. Matt Willis.
Thank you, Scott. Good afternoon, everyone. Matt Willis, Public Health Officer. It's great to be here with you this afternoon. We've got a lot of ground to cover in the topic of the challenges that are facing us with regards to our COVID-19 pandemic response in Marin County. So I'll start by sharing slides. I have a presentation. I'll go through some of our numbers and then, oops, I need to share my screen with you. I'll start with some of the numbers that describe our status currently, and then we'll move to questions and answers. Hopefully we'll have at least 15 minutes for questions and answers. And I know Scott has assembled some of those already, and then we can get to those that might be in the chat, and which Scott or Alan will help moderate for us. Scott, can you just verify whether or not you can see my screen there? Before I move on, I've gotten partway into presentations and realized too late that no one can see my slides. I just want to make sure.
It's looking just fine, Dr. Willis.
It's right. Okay, great. Thanks. So here's our current status. This is the number of cases we've had since the beginning of the pandemic in Marin County. Thinking back to early March, our first cases were right in the beginning of March. It was a gentleman who unfortunately eventually passed away. Our first case was also our first death in Marin. And this was someone who was a passenger on the Diamond Princess cruise ship. If you remember, that was one of the first recognized outbreaks where we learned a lot about just how infectious and transmissible this virus is because of the high number of people who were on board that ship who were infected, including our first case here in Marin. We've had a total of 5,320 cases, 185 people in the hospital with 100 total deaths. Importantly, I've responded to some questions on this recently, and it makes a lot of sense. There was a question that if we've only had 185 in the hospital and 100 have passed, does that mean that more than half of the people who end up getting hospitalized actually pass away? And the answer is no. In fact, a very small minority of individuals who have been hospitalized with COVID-19 in Marin County have passed away, something like 5%, 3 to 5%. But the 85% of our deaths, the majority of our deaths are people who are living in long-term care facilities. And we'll talk more about that as one of the sources of both cases and mortality in Marin. But in most of those cases, those are individuals who, based on the family's wishes or that person's pre-identified wishes, did not want heroic measures or to be transferred to the hospital and into ICU level care with intubation, et cetera. And so in the majority of those cases, those people who do pass from long-term care facilities will do it at that facility. So they're not hospitalized. This is just to show you where we are. This is to invite you to look on our website at any point. Any of you would like to be updated on our current numbers. We update this each day at 4 o'clock. And it's there, coronavirus.marinhhs.org. And you can just scroll through and browse this page. It starts with this as the summary of our status. And then through a variety of different pull down options, you can look at different aspects, whether it's what's happening in our schools, what's happening in the community, what's happening in facilities, our testing rates, demographic characteristics, et cetera, of the epidemic as it evolves. This shows that we have hit that exactly 180,000 individuals tested. That was, again, as of this morning, but it's now above that number, but and it'll be updated daily. So that's about exactly half of we have 260, so that's 300. So yeah, that's more than half of our residents in Marin County have been tested for COVID-19. This is importantly what I look at most closely. The case rates are important, but when you think about it, what we're really trying to do ultimately is prevent people from getting very ill and passing. And so hospitalization rates are even more important than case rates in some, in many ways, especially since we're also concerned about surges into hospitals that surges in cases might lead to, and we want to protect our hospitals. So this is also on the website and something I look at each day, which is the number of individuals in the hospital in Marin and the number of people in ICU. And what you see there is, and we'll talk more about this, but you see a surge that happened in the last week or so, or 3 weeks, I should say, since the beginning of November. We started to see increases in cases, both regionally, Marin regionally and across the state as well as the nation. So for the month of October, we had mostly, about 5 people in the hospital, and we're in a relatively stable pattern. That jumped to about 13 in the hospital. We're now down to 7, but this is because we're a relatively small county. These numbers jump around a little bit, but it is a meaningful increase in hospitalization rates that corresponds with surge in cases since the start of November. This is our epidemic curve. When we talk about flattening the curve, this is what we're referring to. It is the number of new cases per day in Marin County. And what you see is really that the whole arc of our experience since the beginning. And you can see that little blip at the very beginning there in March that led to the first shelter-in-place policy. We were seeing rapid exponential growth in cases across the Bay Area, particularly in the Southern Bay Area, Santa Clara County, San Mateo County. And I, along with 6 other health officers, or 6 total, 5 others across the Bay Area, launched the nation's first shelter-in-place policy on March 16th, followed a few days later by the state and then other jurisdictions across the nation, which successfully did control that first peak in cases. We then saw a relatively rapid acceleration in cases over June and July. That was our peak in mid-July there, and then we've seen steady progress since then, mostly stabilizing through October. Now with the second increase, you might call it, whether it's the second or the third wave, it's obvious that our largest wave was that peak in July there. But we are seeing a significant increase in cases locally. But to put that in context, this is what's being seen across the state of California. And obviously, if you're watching the news, you're aware that we're seeing spikes across the state. This is on the top there. That is that same curve, the epidemic curve, the number of new cases per day across the state of California. And what you see is that peak in July has actually been surpassed by now the peak in cases that's occurring since the beginning of November. And what's most concerning about that, we're seeing more and more cases each day, but the slope of that curve also exceeds the slope of the curve that we experienced in June. And from an epidemiology standpoint, the slope of the curve often predicts the eventual height because it's like a momentum factor. So the fact that it's accelerating so quickly across the state predicts that we're going to have a much higher peak than we did in July in terms of our statewide experience of this pandemic, which obviously corresponds to more cases, more hospitalizations, and more deaths. And so, a lot of the very aggressive policies that have been taken by the state over the last couple of weeks, and some of the steps we've been taking in Marin, which we'll talk more about, are really to try and attenuate, right? Try and address that rapid acceleration we've seen just in the past few weeks. And you're just beneath there, you can see our curve as it relates to the statewide curve. While we are seeing a blip there in early November, it's nothing compared to the acceleration we're seeing across the state. So there's something that we are doing right and something that we really need to stay focused on protecting the gains that we achieved after our July peak. There's the state of California numbers again. And then this is how it, across the United States, even more dramatic increase in November relative to that July peak across the United States. And what's important about that is, and this is another way of representing that geographically, is that when we had that peak in July, it was only happening in some parts of the country. California was seeing surges. There was New York, some parts of the Southeast, but other areas were not experiencing surges. And so there's the ability to summon resources and reallocate resources nationally to those areas that were experiencing surges. We no longer have that ability in terms of a national resource pool because every area is experiencing surges right now, more or less. I mean, even if you look at the far left there, California, despite the fact that we're experiencing such surges, is still on the lower end of the spectrum of case rates compared to the majority of the country. And so it's much more dynamic now where each state and each county in many cases is really on its own in terms of managing hospital surges, testing capacity, et cetera. And then stepping back even further, this is by definition a pandemic being, an epidemic that spans the globe. And we're seeing in other Northern Hemisphere countries, especially, also surges in cases with corresponding increases in restrictive policies, shelter-in-place policies, et cetera, being put in place across many European countries. This is how the governor responded to that surge that I was talking about starting in early November. This was just over one week. You're probably now aware of the California Blueprint for a Safer Economy. This is the strategy that the governor and the California Department of Public Health have designed to help manage the pandemic in the state. Every county is divided into one of 4 tiers, depending on case incidence and percent positivity. Purple being sort of like the air quality, purple being the worst or the highest number of cases, yellow being the best or the lowest number of cases. And then the policies of the different elements of the shelter in place, which is now called the risk reduction framework, no longer termed the shelter in place, but it's essentially the policies that allow what's open or what's not, correspond to those tiers. And what you see on the left there is, at the very beginning of the month, there were only 13 counties in purple. So we had a relatively calm October. Fewer and fewer counties were in that purple tier. We were making progress as a state. And there were 17 counties in orange, including Marin County was in orange at that time. Over one day, the governor, the map shifted. It was on November 9th when the governor said that now there had been all of a sudden 41 counties were in purple. The largest single movement backwards we'd ever seen in the state. Marin County moved from the orange tier to the red tier on November 8th or November 9th. And this is what more or less what the map looks like now. If not, there'll be an announcement later today with a new version of this map. And I imagine there'll be even more purple than there was on November 9th. And then just pointing out what I had already pointed out before, that the slope of the curve in June was not as steep as it was and has been in November, which is concerning from a prognostic standpoint. This is Marin County's numbers. We, on the far left, you see there 6.2 cases per day per 100,000. That's the case rate, the raw case rate. That's, we have 260,000 residents. So you basically multiply our adjusted case rate by 2.5, and you get our total cases as a county as a whole, with 1.5% positivity among all residents. And then we look at the percent positivity there, the 1.3% health equity quartile positivity rate. And that's to make sure that we are testing enough and addressing any increase in virus transmission in our most marginalized communities that have been most deeply impacted. And it's reassuring to see that our percent positivity in those communities is about the same as it is for the community as a whole. And that's partly because we've been focusing a lot of our strategic response in addressing those communities that have been disproportionately impacted. And then on the right there, you see that the case rates for the state as a whole, 16.5. This is a week old. That number has increased dramatically. It's now closer to 25. Marin's is still about 6. So we're about a third to a quarter the rates that are being seen on average for the state. This is another way of showing that information for the region. So these are all Bay Area counties here, and those lines correspond to, over time, their case rates. And what you see here is, it's a busy slide, but just to summarize kind of what's important about this, is that the Bay Area on the left side, in early September, our case rates were relatively similar, one county to the other. We were, between 6 and 10, with the exception of that one that was higher, which is Sonoma County, which was in purple, and has remained in purple. but the rest were in either red or orange tier, and moving together until about mid-October, when the rates started to diverge more wildly across the Bay Area. Our rates did not increase significantly. So that steady decline we experienced through September and October, we've had an increase, a little increase since the beginning of November, but not nearly as dramatically as every other county in the Bay Area. So now we have, by a fairly wide margin, the lowest counts of any county in the Bay Area. What's concerning about that to me is that there is no county as an island, and when every county to the north and to the east and to the south of us is experiencing much higher case rates, it is probably a matter of time before that spreads into Marin, and so we need to do everything we can at the local level to prevent transmission in our everyday lives. And these are our case rates here in Marin, just corresponding to the tiers. And the reason I focus so much on these tiers is because that's what determines, from the state's perspective, what the laws are in Marin, what we are allowed to open or not, and obviously the strong economic implications in terms of our businesses of what we can and can't do. This is another important feature of our pandemic experience, is that we're having a shift in the demographics. Those blue bars there, those are the percent. These are basically the percent of different race ethnicities of our cases over time. Each bar is a different interval of time, and what you see there is that in the most recent, on the right there, the most recent time frame, where the majority of our cases are among our white residents, those blue bars. And a fewer of our cases are among our Latinx residents, which are the green bars. That's an important shift because it means the virus is flowing in different places through different mechanisms in our community over the past few weeks. And this is what happens in pandemics and epidemics. It moves through different groups depending on the transmission characteristics and the behaviors of people in those different groups. And what we have, and I'll talk more about the different phases. So these are the three phases of the pandemic in Marin. Phase 1, March through April 2020, was mainly travelers. Like I mentioned, our first case, the Diamond Princess, and sporadic other cases, including myself, diagnosed on March 18th. I had been for that announcement of the shelter in place down in Santa Clara County, where there was a lot of virus being transmitted in that environment, and a large press conference where we announced the policy. No facial covering, if you remember back then to March. We were not recommending facial covering. We've learned a lot more about how the virus is transmitted since then. Ironically, we were there to announce that we were, that was a gathering that was prohibited, through what we were announcing, within hours later, such gatherings were no longer allowed. But unfortunately, I think that's where I was infected. And that, and then we had other sort of sporadic cases like my own, but the case numbers were much lower. We would have 3 to 5 cases total a day at the most back in that first phase from March through April. And then phase 2, May through October, was really kind of the, that big peak that you saw in June and July, was fueled by this as another driver of this pandemic was our essential workers and their household members, primarily our Latinx residents. So, an essential worker, by virtue of an economic necessity, not able to shelter at home, not able to work from home, in more contact with the general public and more contact with their coworkers, and then their household members, living in households where you might have 1 or 2 families actually living in the same space. So the risk of transmission within that household also being much higher, really driving our numbers. Again, some weeks, 80 to 90% of our cases were among our Latinx residents. We're also seeing surges in cases at that time through long-term care facilities. And then this was also when the San Quentin outbreak occurred. In the end, there was about 2,500 cases associated with the San Quentin outbreak. not attributable. I had no jurisdiction. We have no jurisdiction over that facility. It's separate. It's managed by the California Department of Corrections and Rehabilitation, and managed by the California Department of Public Health in terms of the epidemic response. But those were numbers that did contribute, at least in terms of our mortality. If you look at some of the mortality rates, you'll see Marin has much higher rates, and that's because those San Quentin inmates that passed, about 30 of them, are attributed to Marin County. What's important about that is these are settings and people who have less freedom to avoid risk, right? Whether it's economic opportunities, whether it's housing conditions, whether it's members of long-term care facilities or skilled nursing homes, people who are in prison, obviously, much less freedom to avoid risk, and it was in distinct geographic and demographic clusters. The next phase, starting in November and ongoing, is more fueled by social gatherings. We're seeing a larger proportion among our white residents. And what's discouraging about that is that it's often poor choices that's driving that, when we've tried our best to sort of communicate what the elements of risk are. Some people are still not adhering to those guidelines. So there's more freedom to avoid risk, which is what's encouraging about this, is that we may have better opportunity to prevent this surge through behavior change, which people actually have more freedom to make better decisions. And that dynamic is generalized across Marin. So whereas you would have seen spikes in cases in the Canal area of Santa Fe, in certain areas of Novato, certain areas of West Marin where we have more Latinx residents, now we're seeing sporadic cases across the county. So if you look at every day I have a map where I'm able to see where the cases are emerging. And now I see more Mill Valley, Tiburon, Larks, Belvedere, San Anselmo, where I live, but and as well as the Canal and other, but the difference in the signal between those areas is much less. In fact, we're actually seeing more cases in other areas. Moving on to schools. So this is a dashboard that is now available also on the website that I mentioned. It shows, it's updated weekly on Fridays and shows the total number of cases. And incidentally, I updated this on Thursday, so there may be a little more than this now, but this basically offers the picture that we've opened 71% of our schools in Marin County, one of the counties that has opened the largest number of schools. And the fact that we have also some of the lowest prevalence in the state right now, I think is an encouraging sign that opening schools in and of itself is not a significant driver of community-wide prevalence. Because again, the county that has some of the lowest rates currently, ours, is also the county that has opened some of the highest number of schools. 82 of our 106 or so schools are open to some form of classroom-based learning. We have now 350,000+ student days accumulated. So if each day that a student is in school is one, we have since September 8th, we count all the kids who are coming into school since that date in Marin. It's about a total cumulative of about 350,000 student days. We've had 0 occasions of transmission of COVID-19 within a school setting. 15 schools as of Thursday of last week, or Friday, 15 students in schools have been diagnosed with COVID-19. All of them were acquired outside of that setting, probably at home from a family member, and one staff member had been diagnosed. So these are some of the restrictions that go along with our current status right now. We are again in the red tier. I made a decision 2 weeks ago to preemptively, when I saw the spikes in cases that I showed you happening early in November, despite the fact that we are in that less restrictive orange tier, we made a local decision to preemptively place us in the red tier to adopt those more restrictive policies in order to continue to protect us and prevent any further spread. A week later, the governor, through that announcement that I mentioned on November 9th, placed us in the red tier, but we had already made that decision a week earlier for ourselves. And that's 50% capacity retail and indoor malls. Places of worship are at 25%. In the orange tier, they had 50%, movie theaters at 25%. And we also prevented any concessions in movie theaters because people are not able to cover their face when they're eating their popcorn and having their soda. Gyms and fitness centers are down to 10% capacity, and indoor pools were closed. Libraries are at 50%. Non-essential office spaces were closed. So offices are only for essential workers. And then the reason I call it Red Tier Plus is that we also closed indoor dining. In the Red Tier policies would otherwise allow restaurants to be open at 25% capacity, but we made a decision in Marin to have no indoor dining, and that's because of the unique concerns about indoor dining risks. We know that when people are gathered indoors, there's obviously a greater risk of transmission when they're gathered across households, and that there's the duration of time is important. So people are not able to cover their faces because they're dining, eating, and drinking. Can be over an hour and a half, 2 hours. Food service workers are, when we look at the occupation of the people who have been infected in Marin County, food service workers are among the highest, or the most risky occupation, if you will. We also have seen evidence from across the nation of super spreader events that have originated in restaurants where an individual may have been at that peak of their infectivity and dining and not covering their face because they're dining, and the others around them similarly are not covering their face. And if the ventilation is not good, especially, you can end up with 15 to 30 cases out of just a given seating in a restaurant through a super spreader event. And then dining also, if it becomes normative and people are eating out on a regular basis, it contributes to mobility. And as this latest directive from the governor for the curfew, indicates that overall mobility is in itself independently a risk for more transmission at the community level. So any sector that brings people out of their homes and more into normal interactions with people who we see as normal prior to COVID-19, in itself will increase our risk for higher rates. And so indoor dining was another contributor to overall mobility that we wanted to take into account. Right now, obviously, one of the concerns, I guess my main concern for the next few weeks is that what I just shared with you in terms of the surges we're seeing, small surges in Marin, larger in the state, or in the region, even more in the state, and then nationally, is that all of this is preceding. It's preceding what we knew to be our biggest threats. It's happening before Thanksgiving. It's happening before people really start traveling for the holidays. It's happening before the weather really starts getting bad and people are being more driven indoors. The weather just started getting worse. It's happening before we've seen any influenza. It's happening before the winter break. So there's obviously a real concern that insofar as we're already seeing hospitalization rates rise across the Bay Area. I just had a conversation with the Santa Clara Health Officer. They're already seeing surges into their hospitals, way more than we're seeing here. If we don't reverse this trend now, we will be in a much deeper hole to try and dig out of come mid-December and into the new year. So the holiday gatherings, I think, is a really important potential driver of this that we need to address. So for holiday gatherings, keeping it outside, the difference between indoors and outdoors is so important for this. When we look at outbreaks that have occurred, almost all of them are indoors. So if you can keep it outdoors, it's way safer. Gathering outside, keeping the gathering small, limiting it to no more than 3 households, keeping them short, no more than 2 hours, and keeping them stable. So picking, we've talked about, we did the social bubble. Marin County is one of the first counties to have this concept of a group of people that you stick with as your hub. Maintaining that approach to your social gatherings over the holiday will be important as well. We also issued a travel advisory recently, followed a week later by the state's travel advisory, which was very similar. essentially the top recommendation is just simply to avoid travel during the holidays as much as possible. If you must travel, a 14-day quarantine after you return is recommended. And then remembering also that if you travel outside of this area, that you are likely to travel to a place where people are less adherent to the standards that we consider as normative here in Marin and across the Bay Area. You know, a lot of places, facial covering is much less common. You know, social gatherings might be indoors without facial covering more commonly. And so avoiding those kinds of gatherings, or if you walk into a setting where that seems to be the norm, really simply just finding a way to absent yourself from that is important. And if you're not able to really guarantee that you've had safer experiences while you're traveling, making sure that you do quarantine when you get home, especially, and or testing 5 to 7 days after you return. And if the test is negative, that's a highly reassuring sign that you had not been infected. Okay, I'm going to just rip through, before we get to some questions and answers, some of the kind of promising, cool stuff that's happening in Marin that's going to help us stay ahead of this. So one is that we have new testing options. We have rapid antigen testing. This is being distributed to local counties from the federal through the state. Binax now is it's almost a credit, you might have read about it. It's a credit card kind of, it's like a little card. It's like a folder, you open it. It has a little slat. You do the swab, you stick it in there, close it. And within 15 minutes, it lights up like a pregnancy test. It'll let you know whether the person is positive or negative. It's a $5 per test. It's great. It's inexpensive. It's diagnosis in real time, and you can do it at the point of care. Unfortunately, it's less sensitive than our standard PCR test. I mean, the standard PCR test is a nasal swab that has to be sent to a laboratory to be tested. It takes a day to 3 days to come back. The problem is that you can get false negatives, which is obviously a concern, which is someone who's infected, but the test is negative. That's the problem with these rapid antigen tests. It also still requires trained staff to administer and read the results. We now have 17,000 kits in Marin from the federal government. We're pilot testing them in clinics, Marin community clinics, hospitals. Marin Health is piloting this, and some of our long-term care facilities are also piloting. So we're going to get some data over the next week. We already have about 200 where we've done both the PCR test and the Binax test to see how they behave, whether the results are concordant or whether they're discordant and in what settings, so we understand really how well that test performs. But that's a potential resource for us. If we know that it performs well enough to roll out more widely. Another important new step for us is the unpronounceable Bamlavibimab. It is a rapid, it's an antibody therapy. So this is a treatment. I just talked about testing this as a treatment. It's an antibody. So as you know, when you're infected with a virus or bacteria, your immune system mounts antibodies that fight that off. This is a monoclonal antibody. So they are able to actually manufacture these antibodies that are mounted against the COVID-19 virus and be infused into your body. So you're basically just getting the antibodies you need without having to wait that time interval for your own body to make it. It helps prevent emergency department visits and hospitalizations if it's given early in the course of disease. It's done through an IV infusion, and limited doses are being distributed now to Marin healthcare providers. I think we've got 50 total doses, and more are on the way. So that's promising. This is the one that's one of the treatments that the president received. Less experimental now, more proven. And then this is our COVID-19 vaccine update. So as you know, Pfizer and Moderna are the two vaccine manufacturers that have completed the phase 3 trials or near completion of phase 3 trials first. The Pfizer vaccine is probably going to be the first to arrive. That's the one that requires ultra cold storage. So it's going to have some logistical challenges in terms of how we would roll that out in Marin. These are mRNA vaccines, another new vaccine technology. It basically has your body manufacture proteins that look like virus proteins, and then your own body immune system will make antibodies against those proteins. So that if you see the virus itself, if you're infected with the virus itself, your body already has the antibodies it needs to fight that virus because you've already had a mimic of those proteins manufactured through this mRNA vaccine. They're phase 3 trials, 40,000 patients. So these are big trials where I think we can really hang our hat on the results when you get that many people. Going 40,000 in each of them, so that's 80,000 total between the Pfizer and the vaccine. And the way they work is that half the people get a placebo. They're still getting the injection. Everything is the same. Even the people who are running the study don't know who's getting the placebo versus the vaccine until the trial is over. And in both trials, about 90 people of those 40,000 in the trial got infected just over the, through their natural life over the course of the study period. And then they look and they say, okay, among those that got infected, who got the vaccine versus who got the placebo? And it turns out almost everybody who got infected in those studies got the placebo, was not vaccinated. And very few of the people who actually got the real thing, the vaccine, were infected. And by seeing the difference between those rates, they can say, wow, this is how effective the vaccine. So the estimates are that it's 90 to 95% effective for both of them, which is really good news. And the Moderna, which came out more recently, is actually a lot less high maintenance than the Pfizer vaccine and much easier logistically from a local distribution standpoint than the Pfizer vaccine. These are some of the testing options. Just wanted to make sure you're aware, if anyone wants testing for COVID-19, the simplest thing to do is to go to that website, the coronavirus.marinhhs.org. There's a data page. You can see all the data that I just shared with you. There's also a testing page where you can go and see what the testing resources are. I won't go through them here. And then get your flu shot. This is typically every year we start seeing it, real influenza, the first or second week of December. It takes a couple weeks to develop immunity after you've had your vaccine. So if you haven't gotten vaccinated yet, this is the perfect time to do it, and your healthcare provider will be thrilled, or local pharmacy, to offer you a flu vaccine, because the last thing we need is to be fighting surges in flu cases at the same time as we're fighting surges in COVID-19 cases. So in summary, you have COVID-19 surges underway. This is probably going to be our largest surge that we've experienced thus far in the pandemic. Marin case rates are rising, but more slowly than most. There are widespread restrictions statewide. We're in tier 2, the red tier as a county. We may be bound towards purple, in which case we would have more restrictive policies imposed upon us by the state. Indoor gatherings are driving our case rates currently. Holiday gatherings and travel are not safe. We've had some promising vaccine news. And remember, please get your flu shot. And that concludes my presentation. This is my now 10-year-old son at the Rosie the Riveter Museum, reminding us that we can do it. Thank you.
Okay. I'm back, Dr. Willis, to vex you with some questions from our audience. First of all, I want to say thank you for what is an extraordinarily informative presentation. The other reaction I have is, and I think I speak for many in the audience today, congratulations for amazing leadership. It looks as though Marin, not only nationally, but also within the Bay Area, has performed extraordinarily well under the circumstances to keep transmissivity and our infection rates low, which clearly is a result of not only community cooperation, but also the leadership that you and your staff have been bringing to this pandemic. So hats off to you. A few questions. Obviously, we've been getting them in, and I'm going to try and get in as many questions as I can from all of our viewers as I can, given the time we have. We probably have 15 or 20 minutes left to be with Dr. Willis here. So you mentioned that there was a 1.5 positivity rate, that Marin is the lowest in terms of daily case rates within the area. One of the questions, and this is from Pam Miggs, was as far as the statistics, which seem to be pretty low, would they be even lower if we excluded San Quentin? And in other words, do all of the data charts that you gave us include the prison population, or is that excluded and we're looking at a different population there?
Yeah, I've excluded San Quentin prison from our data that I presented with you today. We look at both, and because it's actually was an important question in July when there was such surges in cases in San Quentin that we had 2,000 cases. There was a point where there were more cases in San Quentin State Prison than in the rest of the county combined since the beginning of the pandemic. Just, we had an interval about after like 2 or 3 weeks into that outbreak at San Quentin, the number of cases there eclipsed all of the cases that had happened thus far in the county. So I looked at them separately. But the numbers that you see that I shared with you are the county separate from San Quentin.
Okay. You were discussing the different vaccines that are coming to be available soon, hopefully. One of the questions, this is from Susan Blanchard, is will some vaccines be more suited to citizens of a certain age and or risk groups than others? And will different individuals receive different vaccines?
That's a great question, and one that I've been speaking with the other health officers in the region about, because there are multiple vaccine products in different levels of the chain of approval, and using different technologies. So the two that have sort of the two horses that are first across the line in the vaccine race are both mRNA vaccines, and it looks like categorically that both of them are 90 to 95% effective. There are different types of vaccines using different technologies that are still in phase 3 trials that will also, I imagine, come into the marketplace soon and will have different characteristics. It will be challenging, I think, from a logistical standpoint to have an equitable distribution of the vaccine when we have 10 different vaccines to choose from, when we're trying to get it to every single individual and to adjust every single person's personal characteristics in terms of age and comorbidities with the corresponding vaccine product that has been demonstrated to be safe and effective most for that group. So ideally that we would maybe by let's say May, it's probably going to be April or May before the vaccine is generally available for the population as a whole. The first doses are going to be really the Pfizer or the Moderna, and it's going to be for essential workers, first line, that first tier. When we're talking about vaccinating the general population, by that point, we're going to have a much wider range of different vaccines that are probably, now I'm forecasting what I imagine will occur, is there'll be a wider range of vaccines by that point that have hit the market. And then we'll be able to work with our healthcare providers to adjust the vaccine for different people of different characteristics. If it's older, some may perform very well for older residents. That vaccine would be reserved for older residents. There's some that it doesn't matter as much in terms of its performance characteristics, and that would be reserved for just general mass vaccinations where you have, tents set up and you have just the population circulating through for the community as a whole. So, good question. And the answer is it's likely that they will not all perform the same way for everyone. And I think public health and healthcare will do everything we can to try and match the performance of the vaccine with the characteristics of the patient.
And what about pathways? For distribution, are we looking at pharmacy locations, your local doctor, drive-in sites, Starbucks? Where are we going to go for this vaccine when it's available?
I was with you until Starbucks. I think the notion of trying to be working in parallel as much as possible. When in Marin County, you got a denominator of 260,000 people. That's a lot of people to vaccinate. So it's not going to be just one shop. It's going to be working in parallel across the community. To the previous question, the more different vaccines we have available to us, and the more and the easier, the low maintenance, the ones that are sort of lower maintenance right now. The problem is the Pfizer, which is the leading candidate, requires -80 degree storage. which is like refrigeration technology that's very limited in availability. None of our hospitals even have those. So we were having to work with research partners, et cetera, to acquire just the cold chain capacity. That's going to limit the locations in which you can offer the vaccine. Later, with the Moderna and other products, we're going to be able to diversify the network of vaccine distribution and administration. Ideally, what I'd love to see, and I think the other health officers share this view, which is that we would be partnering with pharmacies, with every clinic, with our hospitals, with community centers in the different cities and towns, to have what we call pods, point of dispensing, where you have on a Saturday, you come through. This is, I was just looking at some pictures as well as researching this of Marin County back in the 1960s. Black and white pictures of the polio vaccine, where the Salk vaccine came out and they had it on sugar cubes, and there's lines, of people lining up to get the polio vaccine. It was really inspiring to see what that looks like when the community is invited to into being protected in that way through vaccine. And that's the kind of thing we're going to be experiencing again, I would say, in the springtime, where we're going to have these events where the community as a whole can come, and we'll have the operations ironed out where it's rapid throughput in multiple parallel channels where everyone's going to be getting vaccinated at once in different settings.
That actually leads me to my next question. Undoubtedly, you've seen, as we've all seen, public reaction to not only the prescribed behaviors that are being recommended by public health officials, but also a negative public reaction to the likely distribution of vaccines. What's in store for us if there is widespread failure to get vaccinated and to agree to be part of that public health process?
Yeah, I mean, I think the first thing is that we would expect to be able to articulate clearly the benefits of the vaccine and the risks, if there are risks, in a balanced way, to give people all the information they need to make the best choice. We expect that with that information, and given the risk of COVID-19, that our community will by and large choose to be vaccinated. But again, that's going to need to be a trusted source of information, and we've already dedicated ourselves, I think, to a clear and transparent way of communicating that I think will inspire that kind of trust when the moment comes. The state has already done their part to establish a commission that's going to independently review the safety and efficacy of the vaccine outside of the published studies, or looking behind the data to look at what might not have been published. The vaccine has a PR problem right now because it was so politicized kind of in its early stages. I mean, the president was saying it was going to be available before Halloween, which nobody believed was going to happen. And yet that was the story. And so there was a real sense, and there was polls of Americans that showed that there was a real distrust in the process of the vaccine development and timing that we're going to have to need to address, I think, and we recognize between now and when that vaccine is available. And then, we've been through this in Marin. We have had a history of being a more vaccine hesitant community compared to other communities. And we've developed strategies to help answer people's questions about vaccines and help working with our pediatricians around childhood vaccinations, working with our adult providers around adult vaccinations to really offer them that tailored messaging that every person needs to navigate that choice for themselves. It's very unlikely that the COVID-19 vaccine will be mandatory. It's going to be a choice, and we're going to do everything we can to help navigate people to the right choice, which I'm confident is that they be vaccinated.
Okay, we have a question here from Jane Hurt. I'll just read it. 2-hour limited gatherings. Can the virus not be transmitted? Oh, okay. So the recommended limitation, I guess, is 2 hours for in-person gatherings, whether you're outside or otherwise. And the question is, can't the virus be transmitted in a matter of seconds or minutes?
Great question, and the answer is yes and yes. So the virus can be transmitted in a short period of time. So the best way to think about this is an infectious dose. So for you to be infected, your body to become infected, you have to reach a certain minimum amount of virus particles. And you can get there a variety of ways. You can get there just in an instant. If someone who has a lot of virus sneezes on you, they're not wearing their mask, you're not wearing a mask, and you inhale right at that moment, you got enough particles right then and there to become infected. You're done. If you're with someone, say across the table from someone that may not be wearing their mask, in just the course of normal conversation, where just a few virus particles are being emitted as they speak or as they breathe, and it's going into the air, or the droplets are you're close enough where you're able to inhale those droplets. It might take you longer, half hour, hour and a half, even 2 hours, to accumulate that same number of virus particles that would otherwise just be more rapidly if it was closer contact or someone who's more infectious. So there's different dynamics that contribute to that accumulation of a sufficient amount of virus for you to become infected. And time and proximity. The four factors are indoors or outdoors, mask wearing or not mask wearing, how close you are, and how close you are together, and whether or not that person's covering their face. Those are the determinants of whether or not you have that experience of accumulating enough virus to be infected.
Okay. I just want to say personally, we're so cautious in our house that we not only wear masks, but our masks wear masks. So just for those watching who might want a little tip there. We have a question from Deb Bershad, if I'm pronouncing that correctly. And this follows up from what you were talking about, I think. How can we best communicate with and encourage behavior change with our friends and peers who do not support recommended behaviors, such as wearing masks, washing hands, social distancing? Frequently I hear, I refuse to live my life in fear. Any thoughts on that?
I think we can borrow, getting back to the vaccine question, in 2016 or 13, our vaccination rates in Marin were about 78%. They're about 95% now. We made a lot of progress in vaccines. And one of the principles we learned was that, just simply, saying the same things over and over again from a public health standpoint wasn't as effective as peer-to-peer communications, where people started to recognize that it was a matter of community responsibility and participating in our common social well-being and that is a matter of participating in our welfare together to actually engage in these behaviors. So we learned the same thing also with smoking, secondhand smoking, where people would remind others, you know what, please don't smoke. You'd have someone smoking under a no smoking sign. It's public health intervention to put that no smoking sign up. But the actual behavior change came when people started reminding one another of what the right thing to do is. So I think one of the most important elements for us is to really all be stewards of health for our community and reminding one another. I mean, if someone's not wearing a mask, it's often because they either forgot or it's not on the forefront of their mind. So I think my hope is that we all become sort of deputized. We're all public health together, and that it becomes part of culture. Culture, what's the term? Culture eats policy for breakfast or whatever, but we can do the policies, but the culture really wins. And that's where we own it together. And I think we are well enough off in Marin and our common appreciation of science and of evidence and of community that we can do even better by reminding those that are maybe a little bit further behind that this is something that we do for each other and not just for ourselves.
Let me follow up on the vaccine issue, and this question, if I can phrase it correctly, ties into not only the immunity that a vaccine would provide, but also the immunity that one has from having survived COVID and recovered. This is actually a question from one of our board members and fellow physician to you, Dr. Leonard Hoffman, who asks, is there any way to predict whether the immunity provided this year will help for future years? And I'm reading into it, assuming he's interested in finding out not only about the immunity of those who've survived the disease, but also those who are vaccinated. I'm reading into the question, but I think those are both probably something that would be interesting to hear about.
Yeah, it's such a good question, and it's so hard to answer with hard science because we only have what 9 months totally globally under our belt. I mean, we just had the 1 year anniversary of like probably the very first cases. But in terms of real global experience, 8 or 9 months, where we have actually any real numbers to measure this, and then it's all extrapolation in terms of what would that mean in terms of longer term immunity. There's some really encouraging. I mean, if we follow the trajectory of the science, it was like we don't know what antibodies. First of all, we don't know whether you develop antibodies when you're infected. Then there's okay, you get antibodies, but we don't know what antibodies mean in terms of protection. Then the CDC says, well, it's likely that you have at least 90 days of protection, right? That keeps getting extended. Now we're looking at it's probably more than 90 days that you're protected. Now there's actually studies that now are modeling that look like it's probably going to be potentially years of protection for people who have developed antibodies, which is really encouraging that the vaccine, if it does in fact generate antibodies, which is the principle of the vaccine, that the vaccine would provide life, or not lifelong, but longer term protection. So I don't know that we have a clean answer for that yet, but I would say that the trajectory of the science as it evolves is in a favorable direction where we're predicting longer and longer interval of protection.
So that'll be something we'll learn as it goes along, presumably.
Right, and we know that from like the SARS, there's some depending on the element of the virus. I mean, it gets molecularly complex, but if there are certain antigens on the virus that are more preserved, despite the fact that the virus itself mutates. There's certain elements that are the same across different coronaviruses, and if you can mount your antibody response that you invoke through vaccine against those more preserved elements of the COVID-19 virus or SARS-CoV-2 virus, it's much more likely that those will be longer term protective than those that are mounted against some of the more variable elements.
Okay, we definitely want to let you go, and I don't want to extend this too much longer. I have a couple last questions here. We'll try and squeeze in, and then let you get back.
I've got one. I've got time for one more. Sorry, I have to jump.
Okay, all right. Well, side question is, with all of the questions that I'm not able to ask, is there a good place that folks in the community can reach out either to you or your staff for follow-up on some of the issues that we were not able to cover?
Yes. Yeah. I mean, Scott, if you want to just send me a document with of the questions that we weren't able to get to in the chat,
Sure.
I can send that to our staff to answer, and they'll send it back to you, Scott, and then you can distribute them. Would that work?
Absolutely. Yeah,
Okay.
We'll do that.
Yeah.
All right.
There's a website. Let me just, there's an email for anyone who has questions, COVID-19 at Marin HHS. No, sorry. COVID-19 at marincounty.org.
Okay.
COVID-19.
We'll try and figure out a way to get that onto under our website. And also, as we discussed, I'll get some of these questions to you and we'll follow it up in the days to come. Okay. Lastly, before you sign off, any thoughts about the new administration's announcement of a COVID task force is one of the first things that the president-elect intends to establish, as opposed to the prior administration's policy, which was, there was a quotation from Dr. Scott Atlas of Stanford the other day where he said, the only way this stops is if people rise up. You get what you accept. I don't know if you saw that one, but that was his response to a governor's announcement of more strenuous measures to combat the virus. And his reaction was rise up. Now we have a different administration. Any thoughts about that? Are you encouraged or?
Super encouraged. I mean, we've been struggling in public health at the local level since the beginning of this pandemic to cobble together a response, extracting resources from every corner we can. adopting local policies in the absence of a clear national plan. If you look at what's happening across across the world, there's no country like that. These are in almost every other country. There's a national plan. It makes so much sense. And a country that's as well resourced and has as much scientific power and research power and academic power really, we are so ready for this, and at the end, and all the elements are in place for us to have a really strong and robust national response. And with the leadership now in the task force, I know some of the folks that have been assigned to that task force, super great thinkers, really blending kind of their, the ethical and scientific kind of approach that I think we need to make sure that our response is equitable. One of the key features of this is the disproportional impact of people who have already been marginalized historically, and that needs to be a key aspect of our response. And I think that the elements of that are already built into that task force. So I'm really looking forward to getting better night's sleep, when when those guys are kind of helping call the shots, so that it's not up to all of us at the local level. In the meantime, we know what it takes, right? In our community, we know what leads to transmission of the virus in real life. It's when you're closer together without your facial covering, with all the other stuff that's happening in the political landscape, et cetera. Those natural determinants of transmission. There you go. Exactly. Covering your face, maintaining physical distancing, and especially as we come into the holiday season, avoiding indoor social gatherings outside of your household is vital.
Excellent. We're going to cut it short there. Dr. Willis, we can't thank you enough for your insights and the information. We're going to follow this up, as we mentioned. Thank all of you online who joined us for today. And this will be recorded, as I mentioned. This will be on our website under the archives. I also want to thank our wonderful webmaster, Alan Shavitz, who's always bringing us these programs with the highest level of professionalism and seamlessness. Thank you, Alan, as always. We're going to leave it there. Dr. Willis, be well. Thank you. I'd like to wish everybody a great Thanksgiving. Happy holidays, since we're not going to be in touch until the new year. And we'll see you all in 2021. Thank you all. Be safe and be well.
Thank you. Bye.